especially Professor Stantsev, for the kind invitation to participate to your Congress. I would like to present the transforaminal loop endoscopic discectomy. As the professor from Turkey said, it's a challenge to treat hernias in lumbar spine, especially in the foraminal and extraforaminal region. I will start presenting the world pioneers. First of all, Camping at 1987. He was then the one who established and described the technique and also published the results in clinical orthopedic and related research. After that, American-Chinese guy, the Adony Yang, modified the technique. He created his own technique, and he took the FDA approval with a yes system. His technique called YOI technique. And the next two men was my mentors, Michael Schubert and Sebastian Rutten. I think the most recent pioneer is Dr. Kim from South Korea, which treats hernia mostly in the thoracic spine and not only in this area. The safe working zone called Cummings triangle and is shaped from hypotenuse from an exiting nerve root, the superior articular process, and the end plate of the inferior vertebra. We add some things in the literature with this paper, and we correlate the vessels inside the foramina with the spinal nerve. We also described the different positions of the transversing ligament. So if someone wants to start, a beginner, the indication doesn't differ from microdiscectomy. We have the reticulopathy, the positive nerve roots, the motor neurological lesions, the cauda-equina syndrome, a hernia confirmed by MRI scan, and the failure of 12 weeks conservative treatment like anti-inflammatory drugs, physiotherapies, and all these things. So the contraindications divided in two different groups. The related conditions with the surgical technique like recurrent disc herniations, the scar tissue formations, and of course the patient-related conditions like intercalated disc hernia, the scoliosis, the spondylolysis, the obese patients, some musculoskeletal malformation like Bertollotti syndrome, and of course if we have high and steep iliac crests. Step by step, the technique is here. The patient is in the lateral decubital position. We start with a spinal needle, 18 gouges, target the superior edge of the inferior vertebra. After that, we will go to the next step with a guide wire and muscle dilators, different types of muscle dilators, which create the corridor in order to do the foraminoplasty with 2, 3, 4 reamers, depends on if you use Max More spine or Max More technique or Joy Max techniques. I use both of them. So after that, you don't need to know percutaneous technique, but you need to know the foraminal anatomy. Here is some things inside the operations. With A is the disc hernia, with B is the fat, with C is the middle side of facet joint, with G is the dorsal root ganglion and then exiting nerve root. So the advantages is, of course, a safe and effective technique. We have direct visualization of the pathology. It's a traumatic technique, so we don't have a blood loss. We have a faster rehabilitation. Only 6 hours after the procedure, the patient can go to his home. We use also not sedation and local anesthesia, so we can see the patient all the time of the procedure. we have some disadvantages, of course, like we must select carefully the patients. We don't have a lot of space for surgical maneuvering, and it has a long learning curve. If someone wants to start, he must know exactly the level he wants to start, because it's very difficult for someone to go to L5S1 because it has some anatomical reasons. And if someone wants to start, he can read this article. We published it 7-8 years, I think, ago. I was a young and not experienced surgeon. So I say that L3, L4, and L4, L5 was the best results for someone to start after 3, 6 months, 1 year, and 24 months after the procedure. Here is some photos from this paper. And of course, if the time goes up and we have an experienced surgeons, we even go to extreme cases like this one. So you can do stenosis, especially lateral stenosis in adjustment segment disease, the recurrent disc herniation, the adult degenerative scoliosis. We don't correct the deformity, but only the compressing nerve, nothing else. And this is the indication I said before. Sometimes we have difficult conditions with some patients, which is the best patients, the elderly patient with severe accompanying cardiopulmonary comorbidities, and the patients with Parkinson's disease, and of course, all these patients, which is the elite athletes. It's very difficult patients because it needs to go as soon as possible to the training and to participate. This is my favorite paper, I think. It's concerning 55 elite athletes from Greece. This is 2 other papers concerning the Parkinson's disease. I think the best way to treat this patient if they have problem with compression nerve is to treat it with endoscopy, because sometimes if we do infusion, I see these patients to get worsening than before after the procedure. This is the results, and this is one of the questions. Can we go to L5S1 with transforaminal approach, or can go with interlaminar approach? This is something that it published to a neurosurgery journal, and as you can see, sometimes for experienced surgeons, can go even to L5S1 with transforaminal way, but it needs to be in extraforaminal and transforaminal region, the disc hernia, not central disc. And of course, the same technique with moderate results, I think, can use to patients suffering from rheumatoid arthritis. We have a lot of publications. I think it's about 38 publications in the PubMed concerning this procedure. And the general conclusions and future perspectives. We have performed more than 900 lumbar endoscopic discectomies. It's a very large number, especially for a small country like Greece. Of course, the endoscopic discectomy represents a revolutionary minimally invasive technique. It's characterized by numerous surgical advantages combined with respective open procedure as minimization of intraoperative hemorrhage, tissue traumatization, and skin epidural scar formation. I think is the best for the patient. The increasing familiarity with this technique gradually leads to establishment of novel technical modifications. So we start the endoscopic cliff with expandable cage. The smallest cage is about 8 millimeters. Of course, it's the combination of 2 interventional approaches involving the percutaneous technique and the endoscopic aspect. Safety and efficacy of endoscopic discectomy constantly evaluate from current studies in literature, especially considering short learning curve, complications for beginner surgery, and cost effectiveness versus the current gold standard microdiscectomy. Thank you. I would like to show you a video for a difficult case inside the OR if we have the time. the president.
Yes, of
Go. We
course.
have 4 minutes.
Of course. We don't have 5 minutes?
4 minutes?
Yes, yes.
Okay. The video, yeah. I think we are from European Interbalkan Medical Center. The patient has L4, L5 interbody fusion, and he has adjustment segment.
Sorry.
Not the voice, please, because some things I said is not so good if you know Greek. So we have the transforaminal approach, and this is one of the remarks. It's the Maxport spine through the guide wire. As you can see, with the right way, we decompress the foramina at the beginning. We perform foraminoplasty with different reamers, different size, beginning for 4 millimeter, and sometimes we goes to 9 millimeter. This is difficult because you go, inside the. Sometimes you need to go inside in the value space that we have the fusions. This is something different. I have done it before that. But you need to be experienced. At the beginning, I couldn't do it or to do anything of that. You can go to the next minute, please. The next minute. Minute, yes. Now we put the cannula, and through this cannula comes the endoscope inside the foramina. We put the muscle dilators with the guide wire, and we put the endoscope. We have the coagulate the vessels. We don't have hemorrhage or something, but it's better to start with that, peripherically of the. We decompress the nerve when we see the nerve to palpate without any problem to palpate. As you can see, we remove the disc fragments. We start to palpate. With this technique, it's difficult to have tear damage, but sometimes it happens. In the laminar approach, it's much more usual than interlaminar. But I prefer to use transforaminal because I think it's something very different from microdiscectomy, that we go to the medial side, to the midline. It's okay. Thank you very much.
Thank you very much for this interesting presentation.